Good afternoon. This is Jason Jones of the Community Technical Assistance Center, and I would like to welcome you to today's webinar, Evidence-Based Treatment for First Episode Psychosis, Part 2. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. We are very excited to have with us today Dr. Aruma Bello, Co-Associate Director and Clinical Training Director of OnTrack NY. Once again, thank you for joining us. I will now pass it along to Dr. Bello to get us started.
Hi, thank you, Jason. Can you guys hear me?
Yep, loud and clear.
Okay, wonderful. So let's get started. So thank you once again, everyone, for attending today's webinar. We had a first webinar where we talked a little bit about first episode psychosis and all of the components around treatment and things to keep in mind. And in today's webinar, we were hoping to go a little deeper into really understanding or getting some exposure to what are the tools and strategies that are most useful for identifying psychosis from an assessment perspective, and then also some tools for when you're working with folks to utilize shared decision making as a sort of as a vehicle to engage people and help them think through what services they want and how they might want to work with different providers or different treatment strategies. Okay. So just to recap and remind everyone, and so that we can all start by getting on the same page, let's talk a little bit about what is psychosis. So in general, we think about this when a person loses contact with reality. It's an umbrella term, so it's before we're thinking about specific diagnostic categories where a lot of different diagnoses fall under the individual having experiences of psychoses. And psychosis scares some people, but in reality it could describe a lot of different experiences that many people have. So there's a statistic that tells us that 3 of every 100 people experience psychosis at some time in their lives, and the reality is that most people recover. For most people, it doesn't necessarily lead to like a severe and persistent mental illness. FEP, which is the term that we're going to use to focus on early psychosis, is a first episode of psychosis, or what we describe it as that first phase where people start experiencing true symptoms of psychosis. So what are the symptoms? When I say symptoms, what are we talking about? The first symptom that we're talking about are delusions. And these are false personal beliefs that are not subject to reason or contradictory evidence. Usually they're not explained by culture or someone's religion. The reality is that the person has a lot of conviction around these. They're sort of convinced that this is happening, that this is true, even when there is information that contradicts them. Another group of symptoms are hallucinations. And hallucinations consist of sensory perception. So it could be visual, auditory, tactile, olfactory, or gustatory. And these are experiences without external stimuli. They feel very real to the individual. The senses are definitely lighting up. They're definitely, from their perspective, seeing something. For example, if it's a visual hallucination, but an other person, an outside observer, might not see the external stimuli. There isn't the external stimuli. It's something, but it is something that the person believes. Then there is disordered speech or disordered behavior. These are the hallmark symptoms. So when we talk about disordered speech, what do we see? usually the individual might not be connecting topics when they're talking. They might start talking about one thing and rapidly shift to something else. They might be repeating the same things over and over. They might not be describing ideas in a linear way, in a way that makes sense, that's coherent. And then some of the behavioral things that we might see are inappropriate emotional responses, so talking about something sad and laughing, or just behaving in a way that isn't in sync with the way that they're thinking or what's going on in their lives. Another example is lack of impulse control, so the inability to think in a organized way about how to behave and rather be impulsive in behavior. Sometimes we see this as people taking off their clothes. Sometimes we see it as people jumping into traffic, things like that, where it's just impulsive, lack of control in terms of thinking through things. And then behaviors that appear bizarre or appear to be lacking purpose. So this webinar, as I mentioned, I'm going to try to focus in this first part on what are some ways to engage people with first episode psychosis when you're first interacting with them, and what are some strategies that could be useful when trying to determine and trying to assess a first episode of psychosis or early psychosis. As Jason mentioned in the beginning, I work with On Track New York, and in our first webinar, we discussed what On Track New York is, and it's an evidence-based practice for people with first episode psychosis. It's a multidisciplinary approach that really helps people get back to living a life that they find meaningful and purposeful, so helping people with school and work goals, with their relationship, helping them make decisions about medications, helping them make decisions about therapy. And within this team approach, we work with people for an average of 2 years. But in order to get into our program, we use specific strategies to engage people, because we know that early psychosis, for a lot of people, it's new. They haven't really made meaning of what's happening to them, and it could be a point where it could be hard for folks to say, yeah, I want to go to treatment. I want to go work with a whole team of people. That's a hard step for young people to take. So we've learned a lot of strategies to help engage people and to help understand how to work with them. But in addition to that, our program specifically has criteria. So in order to receive On Track New York services, people need to meet a certain criteria. So our teams are very equipped at learning how to assess. And I say all of this because this may or may not be useful to providers to the extent that they need assessment strategies. If you need to determine something immediately, some of these strategies could be really helpful. If you know you're going to be working with a person long term, then you can decide, okay, which assessment strategies am I going to use? What do I need to figure out right now, and what do I not need to figure out right now? And I want to underscore this, because what ends up happening with us in the mental health field a lot of times is that we're very focused on diagnosing. It's part of our training. It's something that we get taught early on. In order to conceptualize and see what's happening, we focus early on coming up with a diagnosis. But the reality is that this is like a first experience. So what's going on might not be very clear for the person. It might not be very clear for the providers, and it could change over time because people are young. So all of that being said, as I discussed the different engagement strategies, it's important to focus on those above and beyond the assessment strategies. So from the beginning, when you are interacting with someone, or when providers are meeting someone, or in our case, in our program where we get a call with someone trying to refer, or the individual is referring themselves, we're thinking of engagement from the get-go. And what do I mean by this? Really spending time, instead of asking people very close-ended questions about what our criteria is to see if they meet the criteria and so that we can make a determination. Instead, spending some time understanding what the person is seeking. What are they wanting from you? What is going on for them? What have they tried? What haven't they tried? What were the challenges in the previous things that they tried? And then really providing information about your program, your services, or the referrals that you're going to be making to other providers about the services that would be helpful to them based on what they described is important to them, based on the kinds of problems that they're describing. So the idea is from the beginning, instead of taking an approach where you're asking a ton of questions geared towards figuring out what's happening, that you're really focusing on building a relationship with that young person, and even with the family. A lot of times our young people come with families, so that you can connect them and help them connect in their minds this idea of what's going on with them and how treatment could be helpful. A lot of young people who experience FEP and first episode psychosis, the reality is that they haven't necessarily interacted with mental health services before. Most of our young people were doing well. They were living normal lives, and now something's happened. Something's shifted. It could be in the last couple of months. It could be in the last year, where their life has drastically changed, and they're trying to understand what's happening to them. And it might not be common sense to them. It might not be important to them to think, oh, what I need most right now is mental health services. So for us, the impetus is on us to try to connect these dots for individuals and families around why these services, what services you can offer, and how it could be really helpful in this individualized way for what is important to that young person. An example, somebody might come in and say, all I really want is to try to get a job. I think that what's happening to me is I can deal with it on my own. I think that it was stress-related, and what I really want to focus on is getting a job because I lost my job. And then when you describe your program or whatever you're able to do, and on track, we're able to provide people with support around school and work. That's how we connect the dots for them. We might say, working with our team, one of the things we can provide is support around this. And we have a supported education and employment specialist that can work with you on this goal. So the idea is that you're really linking what people are identifying with what you can offer. The other thing to really understand, especially in these beginning stages where people are trying to make sense of things, is the role of self-determination. And this is important for recovery for everyone, but it's important for young people who are still developing, who are still growing, who are still trying to identify who they are in the world, that we're not pathologizing everything. And that instead, from the beginning, as we're engaging with people, we're considering self-determination, which has been defined as the propensity for an individual to act in a self-directed, self-regulated, autonomous way. It's the idea that people have values, the idea that people have experience, that they have views of how they want to live their life, and pursuing these are important for an individual's personal recovery. And we need to be mindful of this. We need to be respectful of these, and we need to understand what they are. And some research has shown that when we put self-determination at the forefront, it's associated with engagement in positive health behaviors, such as, adhering to treatment, medication and services, or doing other activities or engaging with providers in other activities that promote well-being. So from the beginning, letting the young person be the driver becomes huge and a very important part of our engagement strategies. And how do we do this? And I apologize, the slide looks a little bit it's hard to read, but the idea is that even the language that you're using from the beginning should be empowering language and not power-robbing language. What do we mean by empowering language? You're offering options. You're offering people asking open-ended questions about what they've considered, giving them options about what they may or may not do, rather than saying, well, you should do this, you need to do that. If you don't take your meds, you might end up in the hospital. You really need to stop smoking marijuana, et cetera, et cetera. From the beginning, you're being very, very mindful of how to empower young people as they progress in their work with you. And that helps with engagement and helps people buy into, collaborating with us in treatment moving forward. And sometimes I could feel that because people are psychotic, this is hard to do if they're quite psychotic in the moment. And yet I would say that it's still really important to do across the board. So, and this is what I was just referring to, right? There's the potential. What are the challenges of doing this? One scenario that we see frequently is when the individual is unable to identify symptoms. It could be due to anosognosia, which is defined as a person having a lack of awareness of their own mental illness, or they can't perceive it accurately. Some people refer to that as lack of insight. That could be the reason. There's also other reasons, right? Like somebody could not want to share with you what their beliefs are. Somebody could not want to share all of the details of something, and that could demonstrate itself as lack of insight, but in reality, they might have insight. But putting that aside, for whatever the underlying reason, there might be a situation where the person isn't able to identify the symptoms. They're not going to tell you, I am paranoid, I hear voices, you might start engaging with someone and they might say just like, I don't know what happened. I went to the hospital because my parents took me. I didn't want to go there. I didn't think there was anything wrong. I was just stressed with school. And in that case, the way to try to understand if psychotic experiences are happening is to ask open-ended questions about how the individual understood recent events. Sometimes as people are describing the events that happened or that led up to a hospitalization or led to them leaving school or led to them breaking up with their boyfriend or girlfriend, for example, in the telling of that story, because of the language that they use, because of the explanations that they use, it becomes evident that the person is experiencing or was experiencing psychosis. So it's really important that we take the time to ask these very fluid questions. Another way to get at it is to ask what changes they've noticed within themselves with regards to their relationship, their work, their school. So here, once again, we're not asking, did you hear voices? Did you see things others didn't see? You're rather asking them to tell you what their life has been like to see if you can surmise any symptoms of psychosis. And then you continue probing and building on what they identified as changes in their lives and use real examples and real stories. You might give examples yourself. Some people have told me that it's sometimes hard to leave the house. Has this been the case for you? This is very different from a traditional psychological assessment, right, where we're trying to ask somebody, have you been sad for the last week? Do you hear things other people don't hear? Do you see things other people don't see? Do you feel that people are trying to, watch you or observe you or trying to get you? It changes sort of the content of the questions, where you're getting a richer picture around what's happening when someone isn't able to identify the symptoms. Okay. The other challenge that we sometimes face is when there are different perspectives about treatment. So, for example, the family wants something, the client wants something else. And in this case, you might, or even the providers want something else. So in this case, you want to really lead with what's important to the client. The client might say, I don't want to take medications. But if they say, I want to go back to school, that gives you an opening around how you can help them and connect to treatment, because school can help them. Treatment can help them with school, particularly if you're able to provide multidisciplinary team approach or coordinated specialty care like On Track. Or I want to stay out of the hospital. And that also gives you an opening to help connect people around how mental health treatment could be helpful. You want to provide real examples maybe from other people that you've worked with and how you've helped them achieve their life goals. So it isn't so much about the person showing up for therapy or showing up for their psychiatric appointments, but rather in working with us, we've helped people stay well, we've helped people go back to school, go to work, establish relationships, etc. And if the onset was acute and the client doesn't believe it will happen again, you want to validate this. And then you want to sort of say, we can help you stay well. We can help you try to understand what happened and what are your strengths to move forward. What are the ways in which we can help sustain this? How can we work together to maintain your daily activities, for example? The other piece is when the family isn't sort of aware or buying into illness or treatment options or explanations. So a family member that says that the son is just lazy. You might take some time, even in the beginning stages of trying to engage with them on providing psychoeducation around negative symptoms, for example. Or when the family says, this is happening because of drugs. And once again, providing some psychoeducation in the context of biological and environmental factors in which psychosis arises. When families feel insecure is another one, that they could take care of the person and thinking that the person needs a higher level of care because the symptoms are very scary. You want to explore this and explore their concerns, validate the concerns, and explain to them how you can be helpful, how treatment works, how treatment could work for this young person to sort of help them understand the range of treatment options, and that sometimes just because a symptom is scary doesn't mean it needs the highest level of care. So the other piece when we're trying to evaluate psychosis is not to get bogged down with a lot of trying to diagnose a lot of other stuff at the same time. Because in the early stages of psychosis, it could be pretty unspecific. You might not be able to determine yet if it's, for example, bipolar disorder, because you haven't had enough time to focus on establishing periods of mood changes, or it could turn into bipolar disorder. Maybe the person just hasn't had, a depressive episode yet. So you want to, if you're trying to determine if something is psychosis, and especially if you're trying to determine if it's early psychosis and they need specialized treatment and make a referral, then you want to try to focus more on the symptoms that are pertinent to the psychosis, trying to get a better understanding of date of onset. Is there any substance use history? If there's history of mood episodes, and any general medical conditions. There are different phases of psychosis, right? There's prodromal, which is emerging psychosis that the symptoms are subthreshold. The symptoms are less precise, and a lot of times it might look like just a decline in functioning. Then there's brief or transient, which is schizophreniform, when it hasn't been there long enough, so you can't give someone a diagnosis of schizophrenia, or when you see someone become psychotic because they use drugs, but then it goes away. And then there's enduring, right? There's the idea that a psychosis does require a diagnosis of schizophrenia. It's lasted more than 6 months, or it's persistent, etc. And when we're thinking about our young people, we could be seeing them at any of these stages. For a specialized treatment, like On Track New York, we definitely want them in either the brief, transient, or enduring. Those are the stages where they get admitted into our type of program. But there's other programs in the city that definitely work specifically with prodrome only, and once the person crosses over to frank psychosis, they get referred to other providers. But this is just to help you understand there's different phases of how the illness could look, and depending on when you're interacting and assessing the person or first encountering them, they could be anywhere along this continuum. So here's an example, right? When we're thinking about prodrome versus enduring psychosis, right? So we have Alex, who last summer started feeling like people on the subway were watching him. It was just going on at certain trains at first when he had to go to school, and then it was all the time. He thinks that the people were thinking bad things about him. Whenever he wore blue, that meant something bad to them, and he knew it because they would blink at him in a certain pattern. It became harder to do things I was doing because I couldn't take trains to get anywhere. And then you have someone like Kevin, who says, last winter my best friend said I should start watching this TV show that he really liked. At first I liked it, but then I started wondering if people were talking about me or maybe trying to say something to me. For example, I was breaking up with my girlfriend, and all of a sudden the TV couple would break up also. It was weird, but after watching it more, I just realized that it was part of the story and didn't have anything to do with me. So in Alex's case, we can think of it more as frank psychosis. It's affecting his behavior. He's convinced. There's paranoia. In Kevin's case, he's questioning. There might be some oddness in thinking, but people make all kinds of connections about how things happen. People believe in superstitions. People kind of have beliefs about the world that may not be shared by others, and we don't want to pathologize that. So it could be that something is going on with Kevin. There's definitely some stress, but we can't really say it's psychosis at this time because the symptoms are not concrete, and he can be convinced otherwise. You know, when he says that he realized that that it was part of the story and didn't have anything to do with him, that's not a delusion. That's actually, you know, there's no conviction around it. So it's important when we're hearing people that we're also not jumping the gun or assuming things, and rather that we're understanding where they're at in that moment. So that because what we know is that not everyone who has symptoms that are subthreshold convert to having schizophrenia. So we want to be mindful and really understand where people are at and work with them where they're at. So when we're assessing, once again, we're going back to these symptoms that we talked about earlier, right? The delusions, the hallucinations, the disorganized thinking, disorganized behavior. And for each of, at the symptom level, we're trying to understand, is there an impact in functioning? Are they intense? Are they frequent? Are they across context? Or is it just related to one scenario or one situation? So, for example, somebody who has hallucinations when they haven't slept for 24 hours. That's actually pretty common, and that doesn't mean it's psychosis. And then, as I mentioned in our example, we want to ascertain that there is a degree of conviction, because the person needs to not be able to be convinced otherwise if we're going to call it a delusion. If they can be convinced otherwise, if they kind of are on the fence, they're like, yeah, that's I kind of think that, but I kind of don't. I can understand that this other thing might be accounting for it, then that's not a delusion. So once you identify which of the symptoms meet threshold for frank psychosis, because they're frequent, they're impacting functioning, they're overt, etc., then you can help determine when this started and what's the etiology or what's causing it by doing a timeline assessment. And the timeline really allows you to understand where things are in context rather than isolated. It helps you confirm the absence of symptoms before the earliest date, so you can really ascertain when the psychosis began. And it helps you understand and correlate other things that might be going on, like trauma or mood episodes. So I'm going to give you an example of a timeline. So in this situation, let's imagine that you're working with a person and you are trying to determine what's going on with them, when did it start, so you can figure out, okay, what treatment to provide. You might start asking, okay, so tell me, like, before this, let's imagine they're in the hospital, right? So that's September 2016. Like, right, what happened? What were the significant events? Some of the significant events were that they moved out of state for college in 2015, that they saw a therapist in April 2016, etc. So the idea is that you are working sometimes backwards before this hospitalization. Well, I was living at home in August 2016 for the summer. Before that, I felt like others were talking about me, and the TV was talking to me, and that's kind of why I moved back home. And right before that, in April, I had already been seeing a therapist, but mostly for anxiety. And then in February before that, I was more isolated. I had deactivated my Facebook, et cetera, et cetera. So you can see that, like, in this type of timeline, you can determine, was there a prodromal phase? Was it substance-induced? So we see that, for example, the substance use was about once per week in 2015, but by the time that he became increasingly psychotic, after the psychosis began, it increased to daily. So it might be that it's not substance-induced because he didn't start using daily until after he became psychotic. When we're thinking about the psychosis, when is the frank psychosis? It's a possibility that it was probably in July because that's when he actually felt that others were talking about him, that the TV was talking to him, versus before that, which is just like social isolation, deactivating Facebook, which could be an indication that something's going on. There was definitely some therapy for anxiety, but doesn't necessarily mean psychosis. So in a nutshell, a timeline becomes a helpful tool for engaging people to tell their story, but then from an assessment perspective to understand what's happening, which is very different from sitting there and asking people just questions down the line where they might not remember. Oh, I don't know when this started, or I don't know the first time I heard voices, or what are the voices, or how it impacted my life. So, as I mentioned, you want to get at what's their story. You want to work backwards because it helps with memory, or working forward from important events. like school, college, employment benchmarks. And then you want to integrate information about different people's experience, right? So what does the family say? What do the medical records say? But the most important piece is to understand the person's story and then see what corresponds and what doesn't. So that's it in terms of assessment. Now we're going to switch gears a little bit and talk about shared decision making. And the reason we're going to talk about shared decision making because, you know, there's assessment strategies, but then there's also this idea around, okay, once you start working with people, what really helps them to stay in treatment? What helps them to connect to providers and do so in a way that prevents people from disengaging? And we really think that one of the underlying mechanisms that leads to recovery and helps people engage in a process that leads to them finding their own journey is to utilize shared decision making. And our teams have found this to be significantly important in keeping people working with a team. So when we think about recovery, imagine that this is recovery for one person, one possibility, and it's a pie chart that really identifies all the things that are important for that individual and the percentage of how important it is. And you can imagine for all the different people that you work with how this might shift and how it might look different. But the idea is that when we're providing treatment, we don't just want to focus on what we think are the targets of treatment, but rather we want to focus on what is important for that person and how can the services that we provide help bolster and support people in reaching their goals and in achieving the life that they want for themselves, which, for example, could be, having good relationships, having a certain type of job, finishing a degree, etc. So when we think about shared decision-making, it becomes a tool or a mechanism that we can use for doing this with people. And shared decision-making comes from the medical field, and it's been adapted now more recently for the social sciences and for behavioral health in particular. But it's the process of interacting with patients who wish to be involved in arriving at an informed, value-based choice when two or more medically reasonable treatment options have features that patients value differently. And it's a mechanism to decrease the information and power asymmetry between doctors and patients by increasing patients' information, sense of autonomy, and their control over treatment decisions that affect their well-being. So the notion is that a lot of the treatments that we can provide as mental health professionals are really an option for people when it aligns with their values and their goals, because none of our treatments cure people 100%, right? We don't have one treatment that is for, if we're talking about schizophrenia, for example, there's not one pill. There's a variety of medications, right? And each of them could be reasonable in across contexts, and each of them have different side effects that people might value differently. When we're thinking about psychotherapy, the same thing, right? There's different types of treatments, there's different types of providing therapy to people, different types of therapies and orientations, etc. So the idea is that we need to empower the folks that we work with to be active participants in their care and collaborate with us when making their decisions around care. So when we think about shared decision-making, we think of it as the best kind of informed consent. It's a model of decision-making in which a provider and an individual receiving care move from the person's initial preferences, like what do people think they want, to informed preferences through a process of supported deliberation. And I'm going to describe the process. But the idea is that you're giving people enough information and enough time to ask questions, to understand, so that they can make some informed decisions around how they want to pursue treatment options. It acknowledges at least two experts in the room, right? The individual is an expert in themselves. The providers are an expert in the treatment with whatever profession they practice. And it can help to clarify an individual's values and preferences for decision-making, which becomes really important in understanding why people adhere to certain treatment recommendations and may not adhere to others. So this is the three-talk model of shared decision making, and it's like an iterative process. That's why it's in a circle. The first step is team talk. So the team is everyone. It's not only the professionals, but also the young person, and in our case in On Track, it's also the family members. And they work together in the beginning to set expectations that you're going to make decisions together so that people don't become passive. Then the second step is you're going to, after saying there's a decision to be made, we're going to work together as a team. Now, let's discuss what are the options. And the idea is that you're providing information as a professional around the different options in a way that's usable, in a way that people can understand. And then you're giving them mechanisms for comparing the options, using decisional balance tools, using pros and cons lists, whatever it is that they need, and doing this with enough time, not rushed. And then finally, once all of the information has been conveyed and deliberated upon, then having a discussion around what matters most to the person and getting some informed preferences that can then lead to making a decision. Once that decision is made, if it goes well, it might lead to sustaining that decision. If it doesn't go well, it might lead to the person making a different decision and starting this process all over again with the team. Throughout the whole process, it's important that there's active listening, so paying really close attention and responding accurately to what the person is expressing, and really that you're allowing time for deliberation. If people need more time, if people need to think about it, if they need to talk to other people before they make that decision, to whatever extent possible that's happening. So the key characteristics is that in order to use shared decision-making, there has to be a clear decision to be made. Obviously, there's going to be some situations where there isn't a decision. There aren't options. There's only one thing, and then that's fine. But for most of the work that we do, there are several decisions or several possibilities. Another key characteristic is that the decision-making preference is evaluated, that information is presented in a usable format, and that providers give a range of the evidence-based alternatives. So you could give a recommendation, and you can say, the evidence shows that this works, but you also give the range. It works for this proportion of the population, or we know this in aggregate. We don't know this at the individual level, etc. And that the information includes the strength of the evidence, or if there is evidence against it, we can also talk about that. And then that you're facilitating a procedure to weigh the options, as I mentioned, using pros and cons, or systematically discussing something with someone that gives them an opportunity to think about things. And then at the end, that you're reaching a decision that's at least clear. And even if it's not agreed upon by all parties, right? Maybe you're working as a team and the therapist thinks that this is not a good decision. But because you've encountered this process of deliberation and you've agreed to work through this process, you can all agree that this is the next step, even if your own personal preference is that the client doesn't pursue this. You're sort of agreeing to jump on board. Let's try this out, knowing that, if it doesn't go well, there's another opportunity to make another decision. So I wanted to give you an example of what it might look like, and this is a very simple example, but we have Tom, who's a 24-year-old male who was recently referred to an On-Track team after a first hospitalization for psychosis. He was treated with risperidone in the hospital. He responded well. He tolerated it. When he returns to his third meeting with you, he reports that he doesn't want to take the medication anymore. And this is a very typical example where people, even though they're getting good effects from meds, might want to stop taking them. So this is where the team talk starts. So what is important to Tom? What are your goals and priorities? What would you like treatment to help with? What are the things that bother him about the medication? What are the things that he likes? And helping him understand sort of the range of things, that it's not black and white, I take meds or I don't take meds, but that there's a lot of underlying thinking that's probably happening for him around his preferences and what might be driving his preferences. And you want to spend time discussing that. Then I want you to know that we have a number of choices that we can consider, so that you take him away from like the black and white thinking. Continuing the medication at this dose, lowering the dose, raising the dose, switching to another medication, switching to a different medication, tapering off the medication. So the idea is that there's a range, and depending on what his concerns are, you might choose one of these different things. If he wants to stop meds because of side effects, you might switch. He might be more open to switching medications rather than stopping. And then reviewing the pros and cons. What are the benefits? What are the side effects of each option? And giving him information that he can easily understand, rather than only giving him information that supports a decision that you think he should make, which might be to stay on the meds. And then what are the option talks? So if we stop the meds, your side effects will go away. Research suggests that 80% of people who stop meds will have symptoms return the following year. If symptoms return, they will respond to medication again, but sometimes they don't. If symptoms return, they might interfere with school and work, and there's a chance you might go back to the hospital. We have other options too, like a dose reduction or a medication switch. So it's not that you're refraining from giving your expert advice, but you're sort of explaining the range of the evidence and the pros and cons of the different options so that Tom can think it through. So let's review what matters to you most and think together about how these options might fit into your goals and priorities. Is there anyone else you'd like to involve, a family member, for example? I'll share my recommendation with you, but I will support you with whatever decision you make. It's really important when we're doing this to think through, because like I said, this example is really straightforward around the idea of taking medications. But there's a lot of treatment decisions that people make, whether to meet with you, whether to come to appointments, whether to engage in certain type of therapeutic interventions. Within our team, where it's a multidisciplinary team, people might decide to work with certain team members and not others, et cetera. So the idea is that when you're working with people, we have to think that we are working on a continuum, right? On the one end of that continuum, we have a duty to care. We are professionals who, as you know, professionals have an ethical standard and a responsibility to do no harm. We have to protect participants from the abuse of the mental health system. We know that people have suffered. When we look at the peer movement, for example, we know that the biomedical model is not the ideal for everyone, and we know that on the extreme end of the duty to care, when we think that we know more than that person and we sort of are not guided by individualized care, by recovery principles, by being culturally competent, for example, we tend to overprotect the folks that we work with. We tend to make decisions for them or sort of give them incentives for making the decisions that we want them to make because we assume we know better based on our experience. On the other end of that continuum is an individual's what we call dignity of risk, right? The idea that every person in this world has the right to take risks, they have the right to learn, to make mistakes, and to kind of live life as they choose. But when we're going towards the end of that continuum, the extreme, we can fall into the category of neglect for the people that we're working with, because we're sort of saying, well, because they have the right to try whatever they want, let's see when they hit rock bottom, and then we'll help them. Well, this is what they want to do, so let them just kind of do what they want, and then we're not going to get involved. So what we want to do is we want to be somewhere in the middle. We don't want to be overprotective or we're making every decision for people. We don't want to be neglectful or we're saying, well, if they don't want to do what we were recommending, then it's up to them and let them just kind of suffer the consequences. And instead what we want to do is help people think through what they want to do, respect their dignity to take risks and not project what we think will happen, but support them in those decisions and give them a lot of options for not disengaging from them. So what might this look like? It might be for someone who's making a decision that we think is too risky, that we're giving them supports for making that decision, but not by themselves. So can a team member go along with them, for example, if they're going to do something that's risky? Or when someone wants to stop medications and they might become increasingly psychotic, one of the tools, for example, that we have in On Track New York is what we call a designated observer. And we say, okay, so what you really want to do is stop this medication. Who do you trust? Your mom. So would you take feedback from your mom? What if we have your mom observe you and write down, and in our next session we can go through the changes that she's seen? And then maybe we're increasing our sessions to twice a week instead of once a week. So you're sort of providing all this scaffolding, so you're not neglecting the person to say, sure, get off your meds and whatever happens, I guess you'll just end up in the hospital. But rather you're supporting them in their ability to take risks and understand what's going on for them and understand sort of the range of experiences. And this is really important in first episode psychosis because our young people, this is their first experience, and we all learn across time. So to think that they're going to take advice, to think that they're going to do what we recommend, to think that they're going to hold us as experts and just follow along is unrealistic. What we know is they need to try things. They're young. They're trying to understand who they are in the world, and it's actually quite normal that they take risks. It's normal that they do things that don't seem super, responsible, because that's what part of being a young adult is. So we want to help people and continue to stay engaged with them in this process. So I wanted to share some resources which could be useful. It's the webpage for On Track. It has our manuals, and in our manuals are some of the tools that I talked about for assessment and for shared decision making, and you can access those freely. And I think that's it. We're at the 45-minute mark, so I know that now we wanted to spend some time doing some Q&A.
Yeah, Dr. Bello, thank you so much for the presentation. We are going to segue into Q&A. Just a reminder, everyone, if you do have any questions, please feel free to chat them in, and we will try to get to them before the end of the hour. So the first question that we did have come in from one of our participants was, you talked a lot about shared decision-making. Can you talk through the process of shared decision-making while also trying to involve families and any struggles that may come up?
Yeah, that's a really good question. I think that for our teams who work closely with families, you start with a person's preferences, especially if you're working with an adult, right? You involve the family to the extent that the young person wants the family involved. Our framework for our model is there's a lot of research to show that family involvement with first episode psychosis helps with outcomes. So we try to take this approach where we promote family involvement. And if a person is saying, no, I don't want my family involved, during the time that they're working with their teams, we're trying to encourage family involvement in whatever way could work for them. So that's the first step. Then when we think about shared decision-making, we involve the family in that process. So it becomes all the team members and whatever their opinions are, the young person and the family members, whoever the young person wants to involve in that process. And then the process of sharing information is done with everyone. The process of pros and cons and deliberation is sort of done including everyone's opinions or options. So when you're describing, for example, the benefits of a treatment approach, if we go back to the medication example that I gave, you kind of share all that information with the family as well as with the young person. And it might be that the young person is saying, I don't want to take this medication because it's making me gain weight. And guess what? I am 21 years old and I've gained 20 pounds in the last 6 months. Like it's just not going to happen. And the family might be saying, yeah, but your symptoms went away and you're not being delusional. So in that process, then you're enlisting the family's concerns, the family's worries, drawing them out, and then as you're describing the pros and cons of the different options, you're involving some of the concerns of what the family is going through. So in the example that I described, part of the compromise might be if the person is adamant about stopping the medication, you're involving the family and supporting the young person, but you're sort of not saying, okay, we're just going to go along with what he wants. You're sort of saying, what role can you guys play as a family member in helping to support this decision? You're having closer oversight. Maybe we're having family sessions more readily or more frequently to explain what you're going through, rather than seeing this process where he becomes psychotic and disengages with everyone. How do we kind of get on the same page around this to the extent that it's possible? I hope that answers the question.
No, it absolutely does, and it was incredibly thorough. Thank you. The next question is more so process-oriented, where one of our participants said, I find that if a patient is showing psychosis, to just listen and then let them be where they are for several sessions, this can lead to trust. I have the impression that patients are tired of nobody listening to them, which is indicative of not being heard throughout life. I find to just listen for several sessions and then to know, if I listen for several sessions, they no longer need much of the delusion to protect themselves. Do you find that this technique can work frequently, or did I just get lucky when using this?
No, I think you're actually quite skilled. That's exactly what we would recommend, right? Some people are going to come in and they're going to want to jump right into whatever treatment you're doing. We do a lot of CBT-based treatment, for example. But other people aren't going to want to do any of it. And they just want, like you said, they want to be heard. They want to trust you. And the way to do that is by meeting them where they're at. And sometimes we feel that because somebody is quite psychotic, we're doing them a disservice by meeting them where they're at, and we can't let this go on, right, because it's dangerous. The reality is that if they trust us, as you're saying, if you're taking the time to build that rapport and that relationship, even in the midst of frank psychosis, then they keep coming, and then you have time to do the interventions. If, on the other hand, you're jumping the gun and moving faster than they are, or providing psychoeducation or interventions or whatever it is before they're ready to hear any of it, you might rupture the relationship, and then that's where they disengage and they don't want to come back. So I think that's absolutely right that you take your time. The other thing that we see is when young people come in and they're having a lot of negative symptoms, for example, and then they don't talk. And then the provider, whether it's a social worker, psychologist, or psychiatrist, or whoever is doing the sessions with them, is at a loss, either asking questions or feeling like I have to fill 45 minutes, and what am I doing? This person is not even talking to me. And what we recommend actually is either shorten your sessions if that's possible, or two, can you engage around other things that have nothing to do with asking them questions around their symptoms? Can you play a video game together? Can you watch YouTube videos? Can you talk about other things that are important to them? Can they read a book with you? Can they, anything to try to build that relationship? Because we think that the first piece that needs to be put in place is that engagement, for sure, before anything else.
Great, thank you. And I think along the same lines of building trust is really understanding what the participant wants to get out of the service. And this question really falls in line with that, where one of our participants said, what do you suggest doing if a client or participant suggests a treatment procedure or protocol that is not evidence-based but is their preference?
I think it depends on what it is. I think it's tricky, right? Because I imagine that if you are working solo or in where you don't have a lot of support, it's hard. In our teams, because it's a multidisciplinary approach, you can always sort of take it back. But I think this applies anyway. You take it back to people's goals. So if they're thinking that they want a non-evidence-based treatment, why? What about it? What is it that entices them? What is it they think they're going to get out of it? What is it that, how does it match their goals? And then you can kind of go through shared decision making with them. What are the pros and cons? What do we know about treatments that are not evidence-based? Is it a cultural thing? Like, are we talking about non-evidence-based because it's not evidence-based, that it's been shown to be harmful? Or are we talking about cultural practices? So an example, right? An individual comes in, they come in with their family, they're very religious, and they really think that what's going to help the young person is prayer circles. And we've seen this. So then how can you, that's not counter, it's not evidence-based, but it's not counter to how we can work with people. So can we find some common ground? Can we do what we're hoping to do from an evidence-based perspective, CBT therapy or medications, blah, 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 while at the same time respecting people's cultural values, if that's where the intervention is coming from, people's preferences, and engaging with that. So some of our teams might actually go and talk to the priest or the pastor and help connect with them, since they're the primary support for the person and the family, or encourage them to go to the prayer circles if that's something that reduces their stress and makes the family feel better and they all want to do it. It's not necessarily harmful, while at the same time engaging with you and doing the evidence-based treatment. So I think it depends. It depends on what we mean by not evidence-based, and if in whatever way we can find common ground, we can be culturally competent and culturally humble and sensitive, then you can try different things and they can all be incorporated. We have participants who, for example, want to try traditional Chinese medicine and don't want to take antipsychotic medications. And we wouldn't say, don't go do that. We would say, we can try it. Let's come up with a plan. How do we know it works? How do we know it doesn't work? How do we integrate sort of your cultural beliefs? Can you do both at the same time, et cetera, et cetera? So the trick is to keep that engagement, find some common ground, and be really open to what people want and understand why they want it, what purpose is it serving.
Perfect. Thank you. And we have one last question, which is, when discussing the 3-talk model of shared decision-making, you mentioned using decision balance tools. Can you describe what those are and how they're useful?
Yeah. So there's several decision balance tools. It just depends on what you're trying to talk about. So, for example, using a pros and cons worksheet could be a decisional balance tool, right? It's a tool that allows you to look at both sides of an issue. What are the good things about this? What are the bad things? Or what are the ways that we could support you or not support you? Or what would you like to see or not see? Things like that. Then there's also decision aids, which could help. Decision aids are information, a lot of times they're in written format, that give people information that could help move them towards informed preferences. So it might be, a worksheet that talks about different medications and their side effects, for example, that they could take home and think about it and try to see where they land or what are the things that are important to them. Or it could be information on something that they want to try that you describe to them, but maybe giving them some other type of tool in addition to a discussion with you could help them figure out what their preferences are and what decisions want to correspond to those. A lot of times when we are meeting with our participants, we don't have time to explain everything to them. And we give them information in the way that we understand them. And there's neutral information out there that is written in a way that is easily understood by people. So it's important to use those tools when people are trying to make decisions.
Perfect. Thank you. And with that, we are out of time for questions. But I do want to say thank you to everyone for joining today's webinar. Thank you, Dr. Bello, for such a great presentation as well.
Thank you. It was my pleasure.
Yeah. So everyone, the slides and the recording for this webinar will be up on our website, ctacny.org, within 2 to 3 business days. We also invite you to join us for upcoming events, which can be found on the CTAC website. If you have any other questions, please contact us at ctac.info@nyu.edu. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide any feedback that you have. On behalf of CTAC and our presenters, thank you for joining us today, and have a great rest of your day. Take care, everyone.